The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast. After learning about adrenal incidentalomas and functional adrenal lesions with Drs. Frye and Brunt in part 1 of this episode, we now move on to part 2, focused on pheochromocytomas and Dr. Brunt's expert approaches and considerations for adrenalectomy.
Let's get into probably the most infamous of all the adrenal endocrinopathies, so pheochromocytoma. So this is an excess of catecholamine. So this is primarily epinephrine and norepinephrine. Pheos will classically present with patients that are describing spells or episodes of hypertension, tachycardia, palpitations, and anxiety. And these are symptomatology that correlates with the catecholamine spike. So Dr. Brunt, tell us a little bit about the workup and management. And I know specifically there's a lot of preoperative workup and kind of planning that has to be done. Talk to us about how you think about all of those things.
So as I mentioned earlier, anywhere from 30 to 40% of pheochromocytomas today present as an incidentaloma. They have higher attenuation on imaging, more water-based content. They don't drop out on chemical shift imaging on MRI. They oftentimes have a bright T2 appearance on MRI if they have an MRI first. And so plasma fractionated metanephrines is the initial screening test. There are more false positives with that. Sometimes you'll have a little slight elevation in norepinephrine. And then we go into further testing. 24-hour urine for catecholamines and metanephrines. We don't necessarily do it in everybody if everything fits and the plasma metas and norepinephrines are high. But the majority of patients will get that as well. And then it's important that they be appropriately prepared for surgery, so you need to alpha block them in advance. We predominantly use doxazosin now because phenoxybenzamine has become phenomenally expensive, even for a 7 to 10 day supply. So we usually use that, but people have used other things like calcium channel blockers as well. And they should be blocked for at least 10 days in advance. And the goal is to control the hypertension and manage any tachycardia. It's critically important to not put a patient on a beta blocker until they've first been alpha blocked, because you can get unopposed alpha stimulation and the patient can have a hypertensive crisis. And I've had young patients, otherwise healthy patients, in whom that happened when they present to an outside ER with severe hypertension. They get a beta blocker and they go into cardiovascular collapse, and have even had patients had to be on ECMO or balloon pump as a result. So it's really important to suspect the diagnosis if you have a young, otherwise healthy patient who comes in with severe malignant type hypertension. So that's the important principle. The patient needs to drink a lot of fluids because the vessels are going to dilate. You want to fill up the tank. And then, of course, these patients are monitored intraoperatively with an arterial line, and anesthesia is prepared to manage their hypertension that inevitably results sometimes when you're manipulating the tumor, and typically they're a bit hypotensive once you've got it disconnected because they've been blocked.
That's a great overview of a really tough endocrinopathy to manage, and requires a lot of especially intraoperatively discussion and good communication with the anesthesia providers. So thanks for that overview.
Just a couple other comments about pheos. I think my experience generally is these are more difficult technically because they tend to be larger, and also they can be very vascular. Yeah, and just everybody's anxiety levels raised a little bit because it's a pheo and because of potential blood pressure consequences. And so you need to be prepared. And I think these larger pheos are really best managed in a center where there's high volume adrenal surgery.
That makes a lot of sense. So speaking of another really challenging diagnosis, let's talk about ACC briefly. So this is adrenocortical carcinoma. These are pretty rare cancers, but they have a really poor prognosis, unfortunately. Up to a third of patients will present with distant metastases at the time of initial evaluation. So all of this necessitates an early diagnosis and early treatment. So Dr. Brunt, these are really tough nodules and cancers to be treating. What are you thinking about as you go into these types of patient interactions, and then what's your general approach operatively to these?
Unfortunately, adrenocortical carcinomas don't often present as smaller incidentalomas. I think we go back, but you should always think about it when you're seeing a patient with an adrenal lesion, especially if it's larger. And again, the same criteria apply. They usually have higher attenuation values on CT. Oftentimes they're not smooth, homogeneous. Borders are a little bit regular, and they tend to be larger tumors. The vast majority of adrenal cortical carcinomas we see are very large, 10 to 15 centimeters in size, often have extension into adjacent vessels, left side, often renal vein thrombosis, right side, inferior vena cava. And they can have distant metastases at the time. So it's an aggressive cancer. It's a difficult one to treat. There's not really very effective systemic therapy. So surgical resection offers the best opportunity for cure. And certainly in somebody who has an intermediate-sized lesion, indeterminate, I would err on the side of taking it out sooner rather than later, because I have had patients come in with advanced adrenal cancer who 2 or 3 years before had something that was 5 or 6 centimeters in size, and potentially could have been cured.
Yeah, and I think you and I have actually done a couple of these cases, and they're really tough. A couple other thoughts, for those studying for the boards or for an ABSITE, sometimes we use the lab test DHEA sulfate can kind of tip you off. A lot of these patients have high steroid precursors that are elevated from their ACC. The other thing is classically, these are almost always done open, especially when they're really large tumors. And then, there is one therapy in particular that is often used sometimes in the neoadjuvant, but more commonly in the adjuvant setting, called mitotane. And so the medical oncologist will help us with that. And then I think, I just want to emphasize the point that you said, upfront, R0 resection is really the key here. That's going to provide the best opportunity for the patient to have a reasonable outcome. So very important to have high volume adrenal surgeons that are doing these.
The other point I'd make about adrenal cancers is oftentimes there's some evidence of biochemical secretion of cortisol or androgens. They often are not as efficient about it. They may have conventional full-blown Cushing syndrome, but it's also not unusual to have viralizing features. Anytime you have a patient with an adrenal mass and they have Cushing's but also viralizing features, that should make you a little more concerned about adrenal cortical carcinoma.
Yeah, great point. Thank you for that overview, Dr. Brunt. Any other lesions that we should talk about when it comes to adrenal gland incidentalomas?
There are a couple that I think are important to be aware of. And of course, one is adrenal metastases. You almost always see these in the setting of known primary other malignancy. They have some of the same features we talked about with adrenal carcinoma, but they're usually not as large. And if somebody has a unilateral solitary adrenal metastasis, then it should be resected and not biopsied first. And I do want to say just a word about adrenal biopsy. This is something that is almost never indicated for a couple of reasons. One is it's typically non-diagnostic unless it's an adrenal metastasis. And secondly, it almost never changes your management. You can make your decision about whether to perform adrenalectomy based on the clinical presentation and the imaging characteristics. And we see this done over and over again, including biopsy of undetected pheochromocytomas, which can lead to a hypertensive crisis and complications. And so the role for adrenal biopsy is extremely limited and would reserve it only for somebody with unresectable metastases or suspected infection like TB. The second lesion that doesn't often get talked about, but is actually fairly common, is adrenal myelolipoma. These are benign tumors comprised of fat and bone marrow elements. They have a very characteristic imaging appearance with macroscopic fat as opposed to microscopic intracellular fat on cortical adenomas. They tend to be larger. We commonly have them referred for concern for possible adrenal malignancy, and it's simply a myelolipoma. And these infrequently require removal because they're benign. And as long as you're comfortable and confident about the imaging appearance and the patient's not having symptoms, which usually they aren't, then these usually are not managed surgically.
That's really helpful. Yeah, these are lesions that may not come up on the test necessarily, but are ones that we're going to be seeing clinically, and so really important to be thinking about. So we want to finish up our discussion today talking about adrenalectomy itself, some of the technical aspects. One of the unique things about adrenalectomy is that there are a variety of surgical approaches. Probably the most tried and true version of an adrenalectomy is a transabdominal lap adrenalectomy, but there are other options. You can go robotic through the abdomen. You can do a retroperitoneoscopic, sometimes called a posterior RP approach. You can do open approaches. So Dr. Brunt, talk to us a little bit. You're somebody that does a variety of these approaches. How do you think about which patients, are going to be good candidates for one over the other? How do you think about choosing one or the other? And then we'll get into some of the details of the cases themselves.
One of the things that's really fun for me about adrenalectomy is that it's not one operation. It's several different operations. You got right and left sides, you got transabdominal, you got retroperitoneal, and occasionally open. And so there's a lot of variety in how we approach these. The retroperitoneal approach has become more popular. It can be a little bit challenging in certain patients, and I'm fairly selective in how I use it. Patients that typically we will do transabdominal are higher BMI, so 34, 35 BMI or higher, which is a lot of my patient population, and larger tumors. And there may be other factors as well. About 4 centimeters is as large as I would approach retroperitoneal, but there are some adrenal surgeons that will do tumors that are larger than that. The important part about the transabdominal approach, actually for both of these approaches, it's patient position setup and your port placement is absolutely key. You've got through the back, it's a smaller space, but it is the most direct route to the adrenal. And if you have the patient properly positioned, your ports separated, the ideal patient, it can be a really quick operation that can be done in 45 to 60 minutes. It takes a little more work transabdominally to get back to the adrenals, and I can go through that step by step if you like.
Yeah, and let's dig right in. So let's start with that transabdominal laparoscopic approach. Maybe we can start on the right. Why don't you walk us through that, and then we can move on to the left.
So again, the patient's in a lateral position, arms up and over. They're on a beanbag mattress. It's important to put a gel pad or a roll under the chest wall to protect the axilla. Really careful about all the padding. And then I always mark the anterior and posterior axillary lines before we prep the patient because those are landmarks for port placement. The initial access is usually about 3 fingerprints below and a bit medial to the anterior axillary line. And I use a Verus needle and 5 millimeter port. And then a 5 millimeter more medial port, 12 millimeter mid-axillary port, and a 5 millimeter more dorsal port. And the first step, you don't have to take the colon down. It's out of the way. The first step is to divide the triangular ligament of the liver. And it's important to get the liver really up and off. So you take that all the way up to the diaphragm. You have to be a little careful you get around really posteriorly. You don't get back toward the right hepatic vein. And it's also important not to get into a phrenic vessel or the diaphragm itself. And to get that liver up and off, which can be challenging in higher BMI patients, but take some time to do that and get good access. It's been said that an operation on the right adrenal is an operation on the vena cava, and that's really true. And so typically, once we got the liver up, we incise the peritoneum and retroperitoneal tissue on the medial edge, have a positive identification of the vena cava, and work right next to it, and just kind of carefully tease that away. I usually use an L-hook monopolar energy device for that because you can just slide under and lift. And then we'll use an advanced bipolar for the other parts of the dissection. And the key is to get around the adrenal vein, which is short and wide. Be very careful with that. Carefully clip it, divide it. And then there are multiple arterial feeding vessels that usually can be taken with an advanced energy device. The inferior medial border is a little tricky because it swings down sort of toward the cava and then out over the top of the kidney, and you want to positively identify the kidney. And then once you get that freed up in the medial side, then the rest is pretty straightforward, dividing retroperitoneal attachments, and then put it in a entrapment bag and remove it.
Yeah, that's great. Why don't you tell us about the left?
Yeah, the left side is significantly different because you do have to mobilize the splenic flexure of the colon, and that's the first step, all the way over to the medial border of the spleen, and then open up the splenorenal ligament. And the key here is to roll this up and over and out of the way. It's important that you don't go back behind the kidney. It can be easy to do that when you're first starting out because then the kidney falls forward and it's harder to find the adrenal. And then after you've mobilized the splenorenal ligament, open up the plane between the tail of the pancreas and the kidney. And that takes you right down to the adrenal gland. And you just roll the spleen and tail of the pancreas over. I don't use any special retractors to do that. I just use a hunter grasper. That takes you down to the adrenal, usually dissect the medial border a little bit superiorly, come around the inferior medial edge. And then the adrenal vein comes off the medial inferior border to empty into the renal vein. It's a bit longer, isolate the adrenal vein, and then divide the remaining attachments in a similar manner. I will just say I think it's really important that when you're doing left adrenalectomy, it's not just about identifying the adrenal. You also need to have a positive identification of the tail of the pancreas, because there have been instances in which the surgeon took out left adrenal nodule and the path comes back normal pancreas. And those patients often get a pancreatic fistula and leak. So have a positive identification on the pancreas. There are a number of ways you can do that. You should always be able to see the splenic artery and vein when you roll that up, and the adrenal sitting right on top of the kidney.
Yeah, great reminder of high-yield things to be looking for during that case. So let's just finish up by talking about the retroperitoneal approach. I know this is something that you specialize in. It's a challenging. A lot of the anatomy is a little bit different, especially for general surgeons. We're not quite as used to going from that posterior approach. So how do you think about right and left RP approaches?
So I actually learned how to do this from Martin Waltz in Essen, Germany. I visited him over 15 years ago, and the day I was with him, we did, I think, 4 adrenalectomies, and he's very, very efficient with it. The patient is the patient positioning is key. So they're in a prone position. We used to put them in prone jackknife, but now the legs are out just a bit more and just kind of flexed up at the knees. And we put a roll under the pelvis and one up by the chest, because you want the abdomen to be free to kind of push forward with gravity. And then it's 3-port access technique. We do an open insertion of a balloon tip cannula at the tip of the 12th rib, and get into that retroperitoneal space, bluntly dissect it with your finger, and then with palpation, put in the 2 5-ports before you put your laparoscope in. And one is just lateral to the edge of the paraspinous muscle, and the other one is more posterior. You do have to have the patient draped all the way down almost to the edge of the table. And then the insufflation is done at high pressure, 25 millimeters of mercury, which is another brilliant innovation that Martin Waltz did. And bluntly dissect the space with the laparoscope, and then use an advanced bipolar. You got to push the kidney down. You can't get up to the adrenal unless you really get the kidney down. And you do some lateral dissection, but if you go too far lateral, you get in the peritoneum. And then also, if you go too far cephalad and you get into the peritoneum, that's a problem, because then the CO2 gets into the intraperitoneal space, and your retroperitoneal space starts to collapse. So it's important to stay extraperitoneal in the retroperitoneal space, and then get up to the adrenal and dissect. The dissection is the same. It's just the exposure is a little bit different. And in the retroperitoneal approach, we typically will take the vein with an advanced bipolar device and don't clip it. I use this for smaller tumors, 4 centimeters or less. It can be a little challenging to get it in the bag, and then it's usually pretty easy to remove. It's really, I think it's important to think about your orientation and anatomy, because you can get disoriented. If you're doing a right side, the vena cava is going to be to the left of the screen. And if you're doing the left side, the adrenal vein is going to be to the right and the kidney down below. And so you have to just constantly remind yourself of your orientation, because it's a little bit different. But it's in the properly selected patient, it's a really nice, efficient technique. And I do think the patients maybe hurt a little bit less afterwards. It is important to close the lumbodorsal fascia as you exit the space, and they don't get any ileus at all.
Yeah, and I've heard, one thing that's frequently talked about is these RP approaches can be especially helpful for patients that have had a lot of intra-abdominal surgery and have a lot of scar tissue there. So
that's right, and I think the other situation is for bilateral adrenalectomy, because you can do both sides without having to reposition the patient, whereas a transabdominal bilateral is 2 separate operations totally.
Yeah, that's a great point. Well, that wraps up our time for today. I first just want to thank you, Dr. Brunt, being so gracious with your time and giving us a crash course on an organ that you know so well. So thank you so much for that. And we'd just also like to thank everyone for listening in today. Hope everyone learned a lot from our conversation. If you want a more comprehensive and deeper dive look into the adrenal gland, we encourage you all to check out our chapter that Dr. Brunt and I wrote on the adrenal gland in the 9th edition of the Washington Manual of Surgery. Thanks so much, everyone. And thank you, Dr. Brunt.
Thank you. It's been a pleasure to be with you today. And if you all have any questions out there, feel free to reach out. Thank you.
We are Drs. Paul Wise
and Jeff Platnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.